We'll start it, sir. A very warm noon to everyone. I am delighted to welcome you today's webinar entitled Qualitative Research. It's time to think beyond numbers. I am Dr. Varsha Predekar, Research Associate for the Project Core under the NIHR Global Health Initiative on Oral Health at Jamia Millia Islamia. On behalf of our team, I extend a warm welcome to all our distinguished participants who have joined us from the various dental public health background across the country and internationally. Today, we are here together to explore the profound potential of qualitative research in dentistry, a methodology that developed deep into the human expertise, uncovering the stories, perspectives, and the values that often goes undermeasured by the numbers alone. Our session will be one and a half hours with the last 30 minutes dedicated to a Q&A round. So I request all the participants to keep themselves mute during the session. If you have any queries during the session, please write them into the chat box and we'll address them at the end. Or alternatively, you can also raise your hand during the Q&A to ask your question directly to the speakers. Thank you all for the joining. Now, I would like to invite our principal investigator of the Project Core, Team India, Professor Abhishek Mehta. He is a professor at Dental Public Health at the Faculty of Dentistry from Jamia Millia Islamia. Sir, please take the platform and introduce our guest speaker of the day. Over to you, sir.
Thank you, Barsha, and warm welcome to all the dignitaries and students who have joined here. It's my honor to welcome us Dr. Yu Kwong Lee from Department of Primary Care Medicine, University of Malaya, Malaysia. He's the head of research training unit at the faculty and is the e-learning lead under eHealth unit. He has conducted and published qualitative research across a range of topics, which includes shared decision-making, type 2 diabetes, HIV and aging, cancer treatment, and prevention and clinical guidance adherence. He's in the editorial board of various journals, prestigious journals like BMC Primary Care Medicine, BMC Medical Education, and he exemplifies his commitment to transforming healthcare delivery, particularly in resource-limited setting. Dr. Lee will be discussing the topic of qualitative research on our request as a part of a two-lecture series. Today's lecture will be on the introduction to qualitative research, and the second lecture will most probably be held in someday in January 2025, where he will discuss the methodology and practical application of qualitative research. Without further wasting the time, I'll hand over the platform to our esteemed speaker, Dr. Yu Kwong Lee, who will lead us to this topic today. And I wish each and everyone a happy learning. Thank you. Over to you, sir.
Thank you, Prof. Abhishek. Thank you, Dr. Barsha, for your kind invitations to deliver this talk. And I'm very happy to make connections with colleagues and researchers from India. It's always heard lots of good things about my colleagues who have traveled to India for conferences. We have gone there to look at the research. We have a big project here in the Department of Primary Care Medicine, also NIH funded, called Respire, which looks at I think it's a respiratory disease across Malaysia, India, and Bangladesh. So lots of good collaborations already established through the same NIH network that brought me to this this talk today. So just let me set up and share my slides. And I just want to be able to see the
Yes, sir.
the chat.
Can see your slides. What you're asking, sir?
Slides, the chat box. Okay. All right.
It's right
yeah.
bottom corner.
Yeah. Okay. So let's get started. I'm going to do a 1 hour lecture on an introduction to qualitative research. And I'm coming to this from a background of someone who who did not have any qualitative background actually. So my background is actually I'm an arts graduate from psychology, and in psychology there was some focus on the human experience, on the human psyche, on human meaning, but a lot of it in social science is attached to statistics. Is attached to tests like t-test or ANOVA, and measuring and translating what humans do, their behavior, into a set of statistics, some percentages. And from there, from my initial undergraduate, I started a PhD, and that's on insulin initiation in type 2 diabetes. And I developed a model of patient values to complement the idea that in evidence-based medicine, there's not just the evidence, but there's also the patient's views and experiences that need to be involved in a decision. And that was my initiation into qualitative research. And since then, I've worked across maybe 25 to 30 projects on qualitative research. It has become more or less the core area, kind of methodology that I'm working with. Some of these projects, similar to what CORE is trying to achieve in India. I heard a bit about your project and interesting work that you're trying to do with community-focused oral health. I've done some research on community level interventions or exploratory research. One is the Penan. Penan are indigenous tribe in the state of Sarawak who live deep in the jungle. They make up less than 1% of the state population, but their leprosy incidence is 30% of the entire state, probably up to 20% of the whole country's leprosy incidence. So this was a key study that we're still involved in, just trying to figure out why is leprosy so rampant in that small community. Another one was in an urban area, so the Rebung B40 project. This was in an urban area. It's the area in the city with the highest density of population per square kilometer, and it has very high density and very low socioeconomic income levels. So we wanted to see if we could try and find out why cancer rates were very high there, why cancer screening was so low when cancer screening is available for free in many of the public health clinics. So we've run a project that used a lot of qualitative research, not just to explore their awareness of cancer, but also to co-develop some of the strategies, some of the campaigns that we wanted to run on cancer awareness. Qualitative research is exciting. It's fun to do at times, but it also can be very difficult. I think some of the projects that I've done stay with me. There was one that we did on ovarian cancer recurrence. So a gynecologist asked me to look at the topic of what happens when patients have a recurrence of ovarian cancer and their prognosis is very poor, and then they often continue treatment even though there really isn't a reason for it. There isn't a very strong case for it. And when the paper was published, eventually in a tier 1 nursing journal, I looked at it and all I could feel was actually sadness, because you think of the names and the people that you've talked to and the interviews that you've done, and then you know that by now, by the time the paper appears, many of them have already passed on. Some of them are difficult stories. I've done one on HIV seroconversion with key populations, with men who have sex with men, and listening to their stories and their relationships and the betrayals was very difficult, very painful to hear. And we often had to sit down and debrief as a research team after the sessions. So that's my journey in qualitative research. And I was thinking about where I came from and where I am now. I just want to be able to introduce you to this methodology that as I said, many of us are not familiar with in healthcare. So who is this session for? I think it's good for you if you want to differentiate between a quantitative and a qualitative paradigm. I'll try and make some comparisons. If you're interested in CORE to explore some of the meanings that people attribute to events in relation to health, And perhaps if you are someone who doesn't want to do qualitative research, but you want to be able to understand what a qualitative research paper is talking about, this may be helpful for you. So just very brief, very introductory. So the outline of the session, there's going to be an overview of qualitative research, just to introduce us to the why and how of qualitative research. Qualitative research rests on very different set of philosophical foundations compared to quantitative research. And I'll show you the two branches that kind of split the research world into quanti and quali research. And then lastly, just so that you have a teaser, I think Prof. Abhishek mentioned that in January, we'll do a more in-depth one on the methodologies or the approaches. But just to have an idea, a taster of what it means to do qualitative research, I will try and talk about some of the key characteristics that go into data collection, that go into planning a qualitative research. So I've got the chat up on my screen. I've got two screens, and it'd be great if you can just type in your qualitative research experience on the scale of 1 to 10, 1 being no experience at all, 10 being you've done lots of qualitative research, and perhaps one thing that you're keen to know about qualitative research from today's workshop. I'll be moving on my eyes on the screen, so don't worry about it. If you can type into the chat, I will try and have a look. So let's go to the thanks. Okay, Santosh is first. So if you can put in, you got a 1. So we've got I think our mean score today will be I mean it's introduction, right? So you'll be 1, 2. So you are 5. So I've got some people here who have some experience already. It's wonderful to see you here joining us today. Yeah, so perhaps just the number will be enough, and that will give me a good idea of who we have joining us today. So I see lots of 5s and 1s. Just keep the numbers coming, and I'll just move on with the talk. Yeah. Okay. So for those of us who have a 1, 2, or 3, what is qualitative research then? What is this thing that is a qualitative study? A lot of people, I'll give you an example why it's important to define it. A lot of people hear the word qualitative research and they immediately think, oh, you're going to be measuring quality of life. So what QOL scale are you going to be using? Because the brain just connects the word quality to qualitative. But here is what it is. This is a dense definition, but qualitative research is this thing that's multi-method. So there are different ways that people collect qualitative research data. You have to collect, once you've collected the data, let's say it's an interview or you're looking at documentation, you need to be able to interpret it in a certain way. There's a certain analytic approach to making sense of words instead of numbers. It's often naturalistic because you collect data from let's say you go the word field work appears a lot in qualitative research. So you're going to the field, you're trying to collect data, just like I mentioned, going to the Penang. I visited them in the jungle, trying to find out what was going on in leprosy. It's very often related to a subjective matter. I'll show you later that when they say subjective, it doesn't mean that it doesn't mean that it's up to you. It doesn't mean that it's up to whoever is doing the research to write whatever they want. It means that you're dealing with matters of meaning. It means that one person's perspective may be different from another person's perspective, and that's part of the qualitative process. So you're trying to look at this interpretation of an event, a phenomena, and you want to be able to capture the meanings that people bring to that event or the phenomena. So immediately you see no numbers. Let's get some misconceptions out of the way, shall we? So as I said, qualitative research is not about two people's writing whatever they want. There is a sense of rigor in qualitative research. There is a sense of that if you're doing a good quality, if you're following methodology that is sound, you should arrive at a credible piece of research. So it's not about it being whatever you want to see, which is often the criticism of people doing qualitative research. Some people think that qualitative research is all about being inspired. You cannot you cannot just sit down and churn out the data. You have to think about how you want to write it. It's almost like an inspirational process when you're doing your results. You're writing up your results. You're telling a story. But it isn't about that actually. There are specific methodologies and systematic processes that lead you to produce the research in qualitative approaches. The last one that I want to shoot down is that only certain people can do qualitative research. So this is a very strong caricature, but you know, qualitative research should be done by people who wear flowery clothes, who play the guitar, who have long hair, who have big earrings, because you know they're not in the numbers. They're all about art, expression, feeling. And I'll let you know that that most of our doctors in our program, the ones who are doing their clinical masters in family medicine, quite a large number do choose to do qualitative research. It's all about being introduced to what it is, the two paradigms of quanti and quali, which we do our workshops for in our clinical masters programs. And then they see the value in it and they choose which methodology is most appropriate for their research question. So qualitative research is essentially something that's exploratory. You start with qualitative research because you don't know what to measure. You don't know actually what's going on. Your research questions are you're trying to figure out the what, the how, or the why of a phenomena, instead of the how many or how frequent, which you will use quantitative research for. And this idea of meaning is very essential in the qualitative approach. To bring meaning in health is very often down to odds ratios, down to number needed to treat. You're trying to summarize in quantitative research a whole population into a single value. I've had a colleague who just came back from a conference in China, and I asked her how it was. She said no one can fight with the Chinese because they have numbers that are 300,000 in their study for a PhD student. I'm analyzing 300,000 people, but when you think about it, all those 300,000 people, they boil them down to one or two numbers. Here's the prevalence for 300,000 people. You could easily do the same prevalence for 500 people, for 1,000 people, for 2,000 people. And that single number is often the defining feature of quantitative research. In qualitative research, it's about the individual. What does this person say? What does this person say that is different from this person? How does this person look at the disease compared to this person? You're looking at a different type of analysis, a different type of approach. So here's a very simple breakdown of comparing between quantitative and qualitative approaches. In quantitative research, you often have an idea of what you want to, of what the hypothesis and the theory is. And what you're trying to do is you're trying to measure whether your hypothesis is correct. So that's why things like statistical significance, associations, logistic regression comes into the picture in quantitative research. In qualitative research, you don't know what the hypothesis is. You don't know how things are connected. In fact, what you're doing is you're just trying to explore. And so you are seeking you're not just seeking the meaning that people have, but you're seeking understanding of it for yourself. In quantitative research, there's very often desire to look at cause and effects. So pre-post, RCTs, these are designs that enable you to look at some kind of association, a connection between different variables that are being measured. In qualitative research, well, here you already know the theory. Here you're trying to generate the theory. You're trying to figure out and try to piece it together so that you have the picture of how the components might potentially fit together. And then from there, you can test the hypothesis. Quantitative is very often objective. They rely on numbers, measurable numbers. Here it's subjective. And this is often as I said, pointed out as a weakness in qualitative research, but it actually it's just a different philosophy, and we'll come to that next in the next section. Quantitative research, because of its emphasis on sample size calculation, is often generalizable. The random sampling and the calculation of sample size. Qualitative research is not generalizable. It is not because it is bad research, but it's because the sampling that you do in qualitative research is what they call purposive sampling. It's not a randomized sampling. So you are looking for people that will give you the answers to your research question. And so having done that, please do not try and say that these people represent the whole population or this group of people. And lastly, you'll find that in quantitative research, the results section, the discussion of the results will boil down to what are the numbers that you found when you're doing your quantitative research. In qualitative research, there are no numbers or the numbers that you present in the results. I interviewed 30 people. I interviewed 50 people. These numbers are not the main results of qualitative research, but it's the words, it is the meanings that bring that are the focus of qualitative research. Another way to think about them is that in quantitative research, you have a process of deduction. You start with a theory, and then you're trying to prove the hypothesis through a set of observations, and then you either confirm or disconfirm the theory. And this deductive process is what defines your usual quantitative research. All your research questions in quanti will usually start with this process. In qualitative research, it is almost the other way around. You've got a set of observations. You're looking at individual people. You're looking at people that you're interested in, people that you talk to across 30 minutes to 45 minutes. And then you produce individual statements, individual pieces of information that you then collate either thematically into a pattern, which you then can say, these are some key themes that emerge, which here is labeled as tentative hypothesis, which you then further combine into a theory. So the process is kind of reverse for quantitative. From quanti is big to small, from quali is small to big, and that would be one way that you can think about the differences. So those are the features. But here's a quick checklist of when you should be using quali and quanti. So you've talked about in the core project. The first one is to have this broad analysis of the disparities in health. So if you know which disparities you're looking for, the subject is clearly defined, you know how to measure those disparities. You don't have to really think about the social setting or the context of the individual. If the data is from a representative sample, if you need someone to be able to repeat the same process across, let's say you're replicating the same thing across different districts, and when you need to produce a generalizable report, you're trying to change policy. You're trying to show that at a national level, this is what's happening. Then quantitative fits. If on the other hand, your research question has these features. Your research question is something that not just you are not familiar with, but perhaps the literature doesn't have much on it. It's something that researchers themselves don't see that much familiarity with. It means that you're going to be doing something called exploratory research. You need to, if you want to link behavior to a wider context, the social world of the individual and why they make those health decisions. And then when you want to look at meaning versus frequencies, so I often argue with my wife. She's a linguist. So she will say, how can you in medicine, in healthcare, try and reduce the human being to just a set of numbers? Don't you think that's being unfair to humanity? And so we always have this discussion, but now we've gotten better. We've resolved our differences. And then when flexibility is needed, very often in quantitative research, you set up the protocol and then you run the protocol. It cannot be changed because you're afraid of bias being introduced. In qualitative research, there's always this sense that when you're going into an area that you're unfamiliar with, when you're doing exploratory research, you're going to have to adjust as you go along. So this would be one of the the features of qualitative research, flexibility. So I'll give you these are some examples of the aims. That means when people think of a research question and they realize that these are the things that you want to focus your research on, this would most likely be a qualitative research project. So if it's about understanding a phenomena or situation in detail or depth, if you want to explore a complex issue, if you're looking at natural settings, if you're constructing a theoretical framework, these are some of the ways in which qualitative research is useful. I'll give you some examples from previous papers. So you can see, let's say one of the aims in the previous slide was to explore views. And this was adolescents' views of thalassemia screening program in Malaysia. And you can see the aim, as stated, is to explore the views of adolescents from an urban school who had undergone a screening program. So exploring views, qualitative fits. This one is to explore barriers. So if you have got an area and you're looking at barriers of facilitators, another fairly common qualitative topic, you can use this one. This is a medical education study. So barriers to effective research supervision in clinical specialist training, experience from our own medical program here, our own university. So we aim to explore barriers to research supervision for the clinical trainees who are being trained in a master's program in the university. So barriers. And this one is to explore reasons. So there were views, there were barriers, there are reasons. These are all things that you will usually write into your title, into your aims when you're doing a qualitative research project. This one is to construct a framework. So this was the project we did for my PhD, and we developed a patient values model with treatment specific values, life goals and philosophies, and the larger personal and social background as some kind of model for patient values from qualitative research. So let's see if let's do this one. So I want you to look at the question, and if you think it's a qualitative one, you type QL into the chat. If you think it's a quantitative one, you type QN. So number one, how could two teenagers catch malaria from local mosquitoes near Washington? Yep. QL, so well done, Ziba. Number two, is this statin useful for patients with stroke? I think you have, I think you have to type one and then QL and one QN, yeah. So yeah, so two is the answers are coming in. This is statin would be a quantitative. Number three, coffee consumption associated with pancreatic cancer. 2QN, 2Q, yeah. Yeah, so what about number four? Does smoking increase the risk of lung cancer and other diseases? Huma is correct. So yeah, Parvati said WN, but I know on the keyboard Q and W are next to each other. And the last one, this one. What are the barriers associated with management of patients with chronic low back pain? Great. So it's going very fast, but I just want to pick out Santosh's one that could be both quali and quanti, and that is actually the correct one when you think about it. You could either survey for barriers, get prevalence if you already know the list, or you could explore the barriers that people have when they with patients with lower back pain. All right, let's move to the next section. So the next section is the philosophies of qualitative research, and this is where it gets a bit weedy, a bit, I won't say technical, but we used to not have this section in our workshops, but we recently put it in, and I find that it's useful to teach students about the philosophies of qualitative research, because of the way when I wasn't taught it, I actually struggled with it, even right till the end of my PhD. So putting it early, I think is good. Now, in qualitative research, the thing that people get scared of is the terminologies. And what you can see is that there's so many things that sound like, is this, it's just not self-explanatory. If I hear the word prevalence, if I hear the word majority, if I hear the word the most, I know what the results in quantitative research usually mean. But when I come to qualitative research, I'm hit with words like symbolic interactionism, epistemology, constructionism, hermeneutics, grounded theory. I can't even guess, and I've tried across the many years, what do these things mean? I can't even guess what they mean just by looking at the terms. Now, the reason why there are so many confusing or difficult sounding terms is because, for me, it boils down to, if meaning is the unit of analysis, it's very important for us to think about how your meaning is going to be derived and who is going to derive that meaning. And in a nutshell, all these words are people trying to give some idea of what they mean when they say that they're going to report about meaning. And this is your usual research continuum that I think many of us will be familiar with. You start with a research question, you do the literature review, this might change your research question a bit. Then you do proposal writing, funding, ethics approval, data collection, data analysis, and finally you have a report writing at the end. So what we found is that a lot of the students in our clinical masters, after we had taught them quantity and quality research, they had this like quanti-quality saying, where you should do quantitative research if you have a lot of time. If you do quantitative research, you spend a lot of time here before the data collection, because you're looking for questionnaires, you're trying to build your sampling frame, you're trying to recruit patients, and then when you run the study, you just run it and it's very fast. And then you analyze, you just put it into SPSS, and then it churns out the data for you. So long time to invest before the study and very short time after you collected the data. And then they said quality is the other way around. You just come up with a couple of questions beforehand, 2 or 3 to submit to ethics committee, and then you just relax until it's time for data collection. And then data collection is where you have to spend a lot of time thinking about how you're going to analyze this data. You have 30 and 40 or 50 pages of free text data to analyze, right? So but actually, you need, if you're a qualitative researcher, you can't relax. The main thing that needs to be prepared before you go and collect the data is you. So you are the main instrument. This is very often emphasized in a lot of qualitative workshops or textbooks. You are the main instrument that's going to be used in the collection of the data. And so part of this preparation or instrument, you, requires working out your lens on the data, which is what we call, the technical term is your epistemology of knowledge. So why do we focus on epistemology or thinking about knowledge when you are doing qualitative research? If you're an interviewer, you want to get in-depth information about someone's experiences and viewpoints. And so this is the unsettling part about qualitative research for me. When I think about the interview, it is to me an artificial act. Would that person think about the topic if I had not asked them about it? It takes place, it's also artificial because it takes place for a purpose that's defined by the interviewer. And when you think about it, I've done research in large research teams where different people interview different participants, and then we come together and then we we collectively analyze the data set. And you'll find that immediately, even without detailed analysis, you know that people from a healthcare background will focus more on the medication or focus more on the process of access to healthcare. People from a non-medical background like myself will focus more on their social background, will focus more on their families, even though we're using the same topic guides. So the interviewer shapes the kind of data that is collected, shapes the kind of data that is going to be analyzed. And it's not just the interviewer's background, but you as a person, whether you're young, whether you're old, whether they know that you're a doctor, whether they don't know that you're a doctor, all these things shape the interview. And so it becomes very unsettling when you think about it, in order that there's so much variation involved in the process of doing a qualitative research interview. So to get through that, what you need to do is you need to think about the philosophy of qualitative research, and why and how people who collect data in qualitative research can trust that the data that they're collecting and they're reporting is valid, is credible. It starts with your topic of interest. So you have a research question. Now, the truth about your topic of interest is what you're aiming at. Now, there are two groups of what, so this ontology is the nature of knowledge. Some people say that there's a realist ontology, which is that there's a single version of truth, an objective truth. Some people say that actually objective truth does not exist, that all truth is relative because of the way people talk about it, because of the way it's reported, because of the various ways that I mean, the measurement paradox is a good example. Something that is moving, once you measure it, you're changing it. So you can't ever get the objective truth. And so these two groups break down into epistemology, or the nature of knowledge, which is your understanding of what kind of knowledge are you able to gather, are you able to collect. A realist ontology will usually lead to a positivist. Positivist is not like positive, negative, but it just means objective, an objective view of truth. So people who do quantitative research, when they report statistics, when they report numbers, they are very often on a positivist view of knowledge. My numbers mean reality. My numbers mean this represents this group of people in an objective way. People who are on the relativist view of ontology, there are two branches. One is constructionist or constructivist, where the knowledge that is collected, knowledge which is reported, is actually co-constructed. So, for example, the interviewer talks to the interviewee, and then as the interviewee replies to them, the interviewer asks a probe, asks a prompt, asks a follow-up question, and then more data emerges. And then this goes back and forth in the conversation until the interviewer is satisfied that they have probed enough about this topic. And so you think about that process is an example of co-construction of knowledge. It takes place between two people. That is a constructivist view. On the other hand, there's and on the other extreme is a postmodernist or relativist or feminist view. So these are views which are driven by underlying goal or underlying philosophy. For example, I want to show how an oppressed group has been systematically oppressed. And everything that I do when I look at their interviews, I'm going to try and bring out that sense of oppression so that I can report how these people have been marginalized. That would be a feminist research approach. So it's not just co-constructing, but there's a particular bias towards the way you want to see or view the data. Now, for those of us from healthcare, this is often the journey. This lady called Kim Watt, she said, I've evolved from a positivist to a constructionist epistemology. She started with objectivist. She said, knowledge exists, it's awaiting discovery. I just have to go out there, talk to people, interview them, I get the knowledge. And then she said, as I talk to people, I ended up with an individual constructivism. The people construct their knowledge, they construct and reconstruct through their interpretation of personal experiences. And then she said, actually, she has moved to contextual constructionism, where there's a social construction of knowledge that's taking place which includes the individual constructions, but it's also constructed through social, cultural, and political context. And then lastly, she ended up here. Actually, she said, I'm part of a radical or relativist constructionism, where there are actually multiple versions that exist of construction knowledge. I'm just going to be reporting one of them because this is the way I approach it, is my lens on it. And so even my own evolution was similar. In my Bachelor's of Arts in Psychology, I memorized the ANOVA formula. I said stats is the way to go. And in my PhD, as I mentioned, I did qualitative research. And right at the end, I thought I was doing something called grounded theory. And then the external examiner, can you imagine this after 4 years of doing your PhD, and then the external examiner marking the thesis says, actually, you know what, you're wrong. You're not doing grounded theory. You're doing something called interpretive descriptive approach. So it threw me off guard completely. Like I thought this is what I was doing, and it wasn't. So I was really uncomfortable at the end of my PhD. And I think where I am now, it's 2024, is that I think a lot of us in healthcare would be like this. We are constructivists at heart. So we recognize that as we interview people, these conversations that take place, there's some co-construction happening. But we are positivists by profession. I think dentistry, medicine, they will still always want to say that when people, you're always reporting it as a truth, as this is the version of truth that I found, and this is the version of truth that I want to report. But you get more comfortable with it as time goes on through people who mentor you, through the experience that you have in doing the research. So what about you? Are you positivist? Are you constructionist? Are you relativist? Yeah, so thank you, Aswini. I think a lot of us, by nature, practicing in healthcare, in evidence-based dentistry, definitely we feel uncomfortable with this relativist ontology. Constructionist, yeah. So. All right. So keep the comments coming. This one I'm very interested to know, so I'll always be watching the comments section. But let's move on to our last bit, okay? The key characteristics of qualitative research. So this is not exhaustive, but if I were to explain what qualitative research is like to someone who has not done it before, these are the things that I would focus on. So it's done in a natural setting. So it's not in a lab. You don't call people into a laboratory and then set up conditions for them to follow so that you can exclude variables that interfering variables. You are the key instrument. I've talked about this before. And lastly, they're always trying to explore what is the process like. What are they thinking? How did they arrive here? Why do they view this thing this way? And the stages of qualitative research are very similar to quantitative research. There's always an idea of conceptualizing your research question. Why is oral healthcare so poor in this community? Or what are some of the barriers to oral healthcare? And then you decide who are the people that you want to sample. And then once you have your inclusion-exclusion criteria, you do data collection, which is usually interviews or focus group discussions. You then have to have a way to manage data. So all this data is all audio recorded. You have to transcribe it. You have to translate to a software that helps you with analysis. And then you analyze the data, usually some kind of thematic analysis or coding, as they say, in qualitative research. And then lastly, when you have a set of themes, you may want to you think about how you want to present. Is it a diagram? Is it a table? Is it you look at a lot of qualitative papers, it's usually a description and a quotation, description and quotation. Now in qualitative research, the key thing is actually that this looks like a very nice circle. But very often in qualitative research, these things may be iterative. And this word will appear a lot in qualitative research, where I'll give you an example. Let's say patient sampling. You initially put an inclusion criteria because you think that these are the people who give you a certain set of views. And then as you talk to them, you have this understanding that actually there are other people out there who also can give you more information on this topic they're interested in. Do you stop and say, no, they weren't part of my original protocol, so I will not include these people, even though they've mentioned this other group of people that I need to talk to? In qualitative research, there's something called snowball sampling, where you talk to one group of people and then it snowballs to another group of people. And so that changes the people that you would be collecting the data from. So you only realize that after you had been collecting data from the original sample. And so you're going back and forth. So in qualitative research, there's usually a confusion between design and approaches. So design usually refers, in quantitative research, when you say design, it refers to choosing the data collection method that will provide the most accurate answer. So you usually say my design is an RCT design. In qualitative research, there isn't really a design. And so because the methods will be, methods are cut across all the different types of approaches. Interview is used in phenomenology, interview is used in grounded theory, for example. So the word approach is often used. And so approach is usually determined by a number of things. And the first one is the topic. So what type of research are you interested in? Let's say you're interested in the experience, the lived experience. Then almost immediately people will say, oh, lived experience, you have to probably apply a phenomenological approach. On the other hand, there's also in health research, and I think we're very fortunate in this regard, is that we are very pragmatic. So very often, if you read qualitative papers that are published in health journals, they may or may not actually mention the approach that they use. And they get away with it because in health research, we are very focused on, here's a problem. We know the problem exists for our patients, and we just want to solve it. So if the data is something that sheds light on the problem and provides some understanding of how we can tackle this problem, I think that's good enough for the qualitative research that we do. So here are some examples of the qualitative research approaches. These will be ones that you may encounter as you read papers. So there's narrative research, which focuses on the stories that people tell. So for example, narrative research, when they analyze the data, they break it down based on who are the actors that people mention, what was the event that they chose to tell the story about, and then they're trying to integrate these things. There's someone called Bakhtin who was actually a Russian philosopher who looked at novels. And so his analysis of novels informs the way people do narrative research. Phenomenological research looks at people's experiences. So as I mentioned, if people say, I want to explore the lived experience or the experiences of a community, it is often using this approach. I define a certain event, I define a certain phenomena, and then I make sure that I ask people about it. Ethnographic research is the classic classic anthropologist research, where they go and live with the community, they observe, they embed themselves in the community, they join weddings, they join funerals, they join childbirth ceremonies, and they observe the culture and they write up about it. Grounded theory research is a full set of approaches, and it comes from this idea that in the past, when people were considered experts in an area, let's say you're considered expert in the area of child oral health, how do they know that what you say is valid? They didn't know. You would just write, I'm the expert in this area, I write a textbook about it, my views, my opinions, and that's what matters. And so this group, these two researchers said, we need to build qualitative research, not just based on experts, what they say, but from the ground up, hence the word grounded. When they explore a certain phenomena, they try and remove preconceived bias, they try and remove any, and they try and have a blank slate approaching the topic, and then they explore until they generate a theory that's grounded. And then lastly, case study research is like studying small cases and going in depth into one person, two people, or even one particular, just a small population, and going really into depth into this case. So each of these would have its own definitions, its own set of origins in history, its own defining features, different types, variations within them. They would have a set of processes or procedures that you need to follow for all of them. And lastly, each of them will have its own set of challenges that people will have to wrestle with when they choose this approach. So these are some methods of data collection, and I'll just try to end with this last bit. So what happens when doctors fall sick? How would you get answers to this question? What will you do? Think of your own colleagues around you. Think of yourself if you're a doctor. There are many ways to collect the data for this thing, right? And in qualitative research, here are some. You could do interviews with doctors. You could do focus group discussions, gather a group of doctors together, and then see as they talk about it, and they discuss it. Are there things that come up in the group? You could observe what happens when doctors fall sick. You follow a doctor who shows initial signs of flu around, and then you make detailed notes about what they do. Participant observation is when you embed yourself as a doctor in a doctor's environment, and then you're a participant there with them. You could do a document analysis, so it's not always collecting verbal data, or not always collecting live data. You could also do things like retrospective document analysis. Perhaps there are notes that you look at. So a very classic one is people who analyze referral notes. These are often qualitative data. And lastly, you could combine all this into some kind of triangulation. So choose the method that best answers your research question, or methods that help you triangulate your results. Here are some papers where I just want to show you that these are how people talk about their qualitative approach. So there's approach, they have to say the topic, and then they have to mention the methods that they use. Yeah, and you'll be able, now after this, you should be able to kind of gauge what they mean. So this one, the approach is ethnographic study. The topic is the experiences of diabetic patients in this Burma community. And the methods would be observations, interviews, field notes. Yeah. So you can see this one they triangulate three different methods. But it's an ethnographic study because they want to look at they want to look at culture of this particular group of Myanmarese patients. Yeah. So all abstracts for qualitative research will usually have this combination. I think this one is this is a more detailed how-to of doing interviews, which we should leave for our next talk. And the last one is actually I just want to talk about the theoretical frameworks. Theoretical frameworks are very important in qualitative research. They help you to sketch out or conceptualize what kind of data you want to collect. So as I said, very often it's exploratory. So you want to go into a topic that you don't know anything about it. But how are you going to do that? Do you start with one question and then just talk your way through the interview? Do you have a very detailed questionnaire and then you just ask question after question? How do you do it? How do you start to explore it? Very often in qualitative research, we use theoretical frameworks. So these are some of the key theories that, for example, we use in healthcare. This is a book called Theory in a Nutshell. And it's quite an old book, but I think it's still very useful. So for example, the health belief model is the one that's probably most commonly used in our department. Sorry, this one, reason action theory, which says that anyone who wants to behave a certain way has an attitude towards that certain topic, has a set of social norms that they think other people would do around that topic, whether it's exercise or smoking. And lastly, a sense of perceived behavioral control, which is that if I want to do something and I believe other people are doing it, but I still cannot do it, I have a loss of sense of control. So we use this to form the questions that we will use to look at a particular behavior. And I'll skip this. This is also a bit more detailed. So if you're going to be doing qualitative research, these are some of the things that you need to have on hand before you get started. You need audio or video digital recorders. You need some kind of perhaps some funding is important because you want to reimburse participants for time or travel, especially if you're doing face-to-face interviews. You need some funding for services, which includes transcribing, and if you're doing in another language, some translation, as well as funding for software. So some of the common softwares that we have in qualitative research are NVivo and Atlas TI. And you need lots of time because the analysis, very often when I say there's a software for qualitative research, the students will ask me, okay, show me which button to press so that it generates the results. And I'm always like, no, it doesn't work that way, even though there's software. Lastly, there's just this thing about rigor, which is that in quantitative research, we are very familiar with these terms: internal validity, external validity, reliability, and observer bias. Which, if you do quantitative research and they look at your study and any of this is missing, then they say, can I trust your results, right? So this set of principles didn't exist in qualitative research before that. But Lincoln and Guba in 1985, they came together and they wrote a concept paper on what does it mean for qualitative research to be rigorous. And these are the 4 criteria that they apply to qualitative research. It needs to be credible. People who read your study need to trust that they need to have a sense that what you're reporting is true to the situation. It needs to be there needs to be some form of transferability. It means that you're reporting things in a way where the themes, the general patterns of what you're reporting can be applied to policy, can be applied to other situations. The third one is dependability. It's not so much replicability because you cannot interview the same people and the same people will not give you exactly the same answers if someone else wants to do it. But if people follow the process of having your raw data to the stage where they look at and they kind of code it using the process that you use, would they arrive at generally the same set of themes? So there's some kind of audit trail there for them to follow. And lastly, confirmability. Can you rule out researcher bias? So there are things like member checking, which is something you only hear in qualitative research. Is that when you have produced your report and you're representing this group of population, this group of people a certain way, instead of just sending it out to the journals and saying, I'm publishing this, I call the people that I interviewed back and say, this is how I'm going to be reporting about you. This is how I'm going to be representing you to the academic community. Do you agree or not agree with how I'm going to be portraying you? So these are some of the things, examples of how these things are met. So I think that with that, in a nutshell, I've got a summary slide. So quantitative research, it wants to explore the meanings that participants attach to things. This word is very key, meaning. Meaning is highly subjective, as I've tried to illustrate some of the examples. So because it's highly subjective, you need an understanding of the philosophy, of the approaches, of the methodology, and the rigor that's involved in qualitative research. And then what I've not touched on is qualitative analysis. So this is not covered in this lecture, which is a whole another section altogether. But we won't touch that today. Okay, so I think go out there. I hope that this talk helps you to get started on doing qualitative analysis. Yeah. Okay, thank you very much.
Thank you so much, Dr. Lee, for the wonderful session. So we'll be asking for the participants if there is any query or any question for the speaker. Please raise your hand or you can type in the chat box.
Dr. Srinivas is asking. Can you unmute him?
Yes, wait. Dr.
Yes, sir.
Hello, can you hear me?
Yes, sir. Yes, sir. We can hear you.
Yeah. This is Dr. Srinivas, Professor and Head Public Health Dentistry, Sebar Institute of Dental Sciences. I just wanted to know, it's been said that it cannot be generalized with the qualitative analysis. May I know the reasons? I feel it's more, especially subjective related topics, it can be generalized, I feel. So one of the drawback of qualitative is mentioned as generalizability, lack of generalizability. But I think some things will be known only through qualitative analysis, the subjective feelings. For example, post-care of dental treatment with reference to attitude of dentists or smoking habits of men in families, when you want to understand some feelings of women, how they feel about. So certain things, I think only through qualitative analysis we can get through, I think. Maybe through focus group discussions or something like that. So that's my point. Is it like it can really not be generalizable?
I think you've made a very good point. I love that you brought it down to that bit in the discussion where you generalize it by saying that this is how we're going to apply this into our practice. This is how it relates to the same situation when it's encountered by doctors. And I think that is a form of generalizability that actually I see very often. And when we write up the papers on qualitative, that usually is the aspect of generalizability that I think is most useful. I also resonate with what you said, that we often write that generalizability is as a weakness of qualitative research. And I think early on, about maybe 10 years ago when I first started doing it, it was always like this standard line that was included in the limitations of the study. The study results are not generalizable because this is a qualitative study. It was almost like it had to be included, like a must. And recently, I've seen that people have begun to understand that generalizability is not the goal of qualitative research. So they've started to drop that line as a weakness of the study, because they're understanding that you're not designing it to be generalizable. So yeah, I think the generalizability thing came in because the quantitative paradigms used to be very strong. So they will always say, I used to get reviewer comments that said, why only 20 people? How was participants were not selected randomly? And that would be the only comment I got on the paper. And so I think it's changed quite a bit over the years. Thank you for your helpful observations.
Okay, thank you, sir. Thank you.
Dr. Lee, there is one more question from SJG College. The question is like, how successful are qualitative methods for implementation research work? Or are they limited to observational types only?
So I actually I really wanted to update that slide. That theory in a nutshell. That slide, the book that had all the theories, and that book was published before implementation science has become a really hot topic, and implementation science uses qualitative research quite heavily, for sure, because implementation science always has this idea of the usual frameworks would have something like the people, the views on the implementation, the item, and then the larger context, and then the policy context, and then trying to figure out how each of these layers influences implementation.
Maybe the reasons of success or failure of particular implementations, if I may say. The reasons, if you want to know why it failed or it was successful, a particular implementation, that can be known from qualitative, Dr. Lee?
Yes, yeah, for sure. So whether something, so that one would usually be considered, so implementation science is often used before the implementation is done, to try and figure out what's the best implementation strategy. And also after it's been done, to try and explore what were some of the barriers and facilitators to the successful implementation. So at both ends of the intervention.
I hope it's clear now. So the next question is from Dr. Aswini. Qualitative research can be valuable for evolution of programs like policies and healthcare systems, but they're not in the evidence-based pyramids. What may be the reason?
So, that's a very good. So I think they're not in the evidence-based pyramid because evidence-based medicine tends to rely on the generalizability of study to the patient, to the so it's a different paradigm. What I would say is that it does get into the evidence pyramid, but not purely as qualitative research. What you want to be looking at if you're trying to get qualitative research results into the evidence-based pyramid is mixed method studies. So do look at mixed method studies so that you have the qualitative, let's say it's called sequential explanatory. So you have the quali one, and then after that, from the quali one, you generate you want to find out how prevalent, for example, are these barriers, how prevalent are these facilitators, and then you do a survey, and that generates a prevalence figure, which would then work its way up the evidence pyramid into the one of the lower levels, if not translated to RCT.
I hope it's clear, Dr. Aswini. So our one more question is there, sir. Could you please explain once again about the subject is unfamiliar? Unfamiliar to what?
Question by Santosh Kumari.
Huh.
It's in the chat.
Also, yes. So the subject is unfamiliar. Let's say you're interested to know about something, but there's very little that's been written about it. So unfamiliar to the academic literature is one, but also unfamiliar to the researcher is another.
From the same participants, one more question is there. Which is the best method of data collection in the qualitative research? Combination of methods or any single method? How could your credibility and transferability be assessed?
So there, I'll give some examples of the combination ones. So what often happens is that we usually stick to one method in the research that we do, but sometimes there's a combination of focus group discussions and in-depth interviews. But very often it's more for pragmatic reasons. We plan for focus group discussions, and then what happens is some people can't make it, but they still want to participate. So we do in-depth interviews. So very often it's quite pragmatic in the way that the methods are chosen. There could be, however, key reasons why you want to do a combination of methods when they provide you different perspectives on the same set of data. So I'll give you an example of one student I had. She was doing a research on BRCA gene counseling for women with the BRCA gene asked to consider prophylactic breast surgery, preventive breast surgery. And so she interviewed the women, she interviewed the doctor, then she found out what were the women's views about this surgery, and then she had observation. So she sat in with the consultations, but not as an interviewee, right? She's just observing how the consultation flows, and then figuring out from there what were the concerns of the patient, what were the concerns of the doctor, were they brought into the consultation. So you see how a different methodology helped her understand the topic in greater detail. I think credibility and transferability. Credibility, I'll give you an example of something called theoretical validation. So let's say you've developed an understanding of a certain topic, and you develop a set of themes. What you can often do is you can try and look for a theory, someone who has published a theory in a similar area, in a similar topic, and then you compare your themes against theirs. If yours is not too far off, then you know that there's some form of theoretical validity there. And that's a good example I can do.
I hope it's clear now. So we have one more question, sir, from Dr. D. Jeba. Is there a sample size estimation in the qualitative research, or we stop when there is a repetition in the themes or answers? What is the good sample size in qualitative research?
Oh, that is the golden question. So we often encounter this question when we are writing our protocols, because you have to put in how many people you're going to be interviewing. Or you encounter the question already in advance when you're doing your budget for your research proposals, because you have to estimate how many people you're going to be interviewing, multiplied by the amount of reimbursement that you need to make. So I'll give you, number one is, there are two things that you need to think about. One is saturation. So at which point does your data get saturated, which is that there's a repetition of themes and answers, as you mentioned. Now, there are papers on this that say that by eight participants, your major themes will be saturated, and they have done reviews of other papers, and at which point it's saturated. So there are papers that support numbers as low as 8 participants. But 8 participants is a really low number for you to get a paper published, I think. So you've also, it's stopped now, but I think at one point I saw a journal saying that you cannot submit qualitative research with less than 20 participants, which, when you think about it, is like a arbitrary number. They're just saying that I want you to talk to people even though you're hearing the same thing over and over again, until you've got at least 20 people who you've talked to. Then I'll trust the credibility of your research. And so I often ask, if you ask me for a ballpark figure, if it's a student with a small budget and a small project, I often ask them to aim for 15 to 20, just to be safe, on the safe side of being able to get it published. But there are papers out there that say that you get saturated very early on, 8 people, 9 people.
And I hope that's it. Any more questions from the participants? So there are no more questions.
Okay.
So for the participants, I'll be sharing you the feedback form on our WhatsApp group. So fill the feedback form so that we can issue your e-certificates. Over to you, Abhishek sir.
Thank you, Dr. Lee, for taking out time and speaking on a topic which most of us we thought that if we do a questionnaire, that means qualitative research. I'll be honest with you, I even thought that few years back. So I used to think that doing a questionnaire, filling a questionnaire from the participant is qualitative research. And now today we have more than 100 participants who are listening to qualitative research and trying to learn, trying to implement it maybe. So really thankful to you, and looking forward for you your second lecture soon. Thank you very much. Thank you.
Thank you very much, Dr. Lee. Thank
Thanks
you all
to
the participants over here.
Okay. Bye. Leave now.
Yes.
Okay, thank you. So I'll get in touch for the next one.
Sure.
Okay.
Sure,
Bye-bye.
sir.